Yes, I understood that I didn't start recording, but I think now it will be quite good. Sorry, Nebojša, we will attach your presentation to, or your speech to the documents of the event. So the first speaker now will be Isabelle Giraudon, if I speak well in French, who is the principal scientist in the European Union Drug Agency. She will speak about the importance of naloxone and take-home naloxone programs in Europe. For decades already, EMCDDA was the EU agency which was collecting and making available so many useful materials and very helpful to us in civil society. The new mandate has started on the 2nd of July this year. And we had very nice discussions with the agency in April, which gave us a good insight that the EUDA will even more and better support civil society in the future. So we are happy that we continue the partnership and cooperation, and we are happy to have Isabelle to tell us this perspective of naloxone from the EUDA position.
Thank you very much. Thanks again for the invitation. That's really a pleasure for me. And it's very important for us. I say us because I see some of my colleagues. We've got Katerina Skarupova, who's been working for many years with your region. And we've got Marika Ferry as well. Marika is the head of the sector to support practices. So of course, she's really involved in these questions of harm reduction, treatment, and the access and availability of these responses. So I'm very happy to see again many of you that I know and to meet the others. I will just maybe share my slides and start this presentation. Okay, can you see it well? Is that okay? Okay, so I'm just gonna start. So preparedness, the importance of naloxone and take-home naloxone programs in Europe. And I wanted to start with these faces and these smiles and all the messages that we can see in many campaigns that have been done in Europe. Naloxone saves lives. I carry naloxone. Opioids can kill, but naloxone saves lives.
Isabelle, sorry to interrupt, but we see the application, not the presentation mode, so the slides are not moving. I don't know if you moved on to the next slide, but we're still on the first slide.
Yeah, I think that's fine, Katerina. Thank you for checking. I'm showing a slide with the faces of people.
Yeah, we still see your title slide.
Okay. Oh.
Maybe try to swap the screens because we don't see the presenters mode, but the application, not the full screen.
Oh, sorry, I'll stop sharing. Sorry about that.
Oh, that was okay then when you.
Yeah. Sorry, I share my screen and then I put on my screen the presentation. Is that okay with you like this?
That's okay now, I think.
Yeah. Okay, so yeah, I just wanted to highlight that basically we want really to put people first and to highlight that there's no stigma. You see on the right side, it's translated. It's "My daughter saved me of an overdose thanks to naloxone." So it's really about the fact that naloxone is a medicine. There are many circumstances where people might have an overdose and where naloxone can actually save lives. And that can be the case for professionals, healthcare workers, nurses, pharmacists, medical doctors, paramedics. That can happen in hospitals and in emergency settings, but actually it can happen everywhere. It can happen in the community. And as we can see from this campaign in Norway, you've got this guy, John, did not die when he overdosed on heroin. He was not alone, and his friend had naloxone. So really that highlights the fact that when people can intervene quickly and they are appropriately trained in the community, and when they have naloxone, they can save lives. I will just suggest this outline for the presentation. A few words on the EUDA, the overdose situation in Europe, the interventions to prevent opioid-related deaths with a focus on take-home naloxone's program, and then a few words on and thoughts about the preparedness. So as you just said before, the EUDA has been on the 2nd of July inaugurated. You see pictures of our director, executive director, Alexis Bousdil, and Ylva Johansson, our commissioner. And you see the keywords for the new agency. It's really about acting today, anticipating tomorrow. And you may want to see at the bottom of the slides the link to our manifesto to know more. But if I may say in few words, it's really about sharing evidence, sharing data for action, and even more than before, working, of course, with all the countries, the neighboring countries, working with networks of professionals, learning and being inspired and informed by the lived experiences, and as well, of course, working even more than before with the civil societies. So we need to tackle many problems, and one of them, of course, is the overdose situation in Europe. You see on the left how the trends have changed over the last years. You see from 2010 to 2022, and how globally we have this increase again in the number of deaths. Provisional data for 23 suggests that it's actually continued, this trend of increase in several countries. And what you can see on the right side is that we've got in the pie, we've got about 3/4 of the people who die who are males. The mean age of the people who died is in their 40s. And as was said before, we know that the numbers are probably underestimated. We only talk about overdose deaths here, and we know that the numbers were at least about 7,000 people who died if we consider the EU, Norway, and Turkey. What is important as well, you see that on the right side, is that 70% of the deaths had opioid present. And if we look at this slide, we see on the left the proportion of drug-induced death cases with opioids mentioned. That means that opioids, usually in combination with other substances, remain the group of substances most commonly implicated in drug-related deaths. And it's a lot of heroin, but there are opioids other than heroin, including methadone and to a lesser extent buprenorphine and pain relief medicines, as well as synthetic opioids that are associated with a substantial share of the deaths in some countries. So what can we do to prevent these deaths related to opioids? Well, there are a range of interventions that are evidence-based and that are available to prevent the opioid-related deaths. And as you can see that on this kind of mosaic, we see that interventions are coherent and integrated, and there are 3 levels. You see in blue, that's about reducing the vulnerability. Importantly, you have here the housing programs, the support to employment programs, and others. On top of this intervention level, you have the interventions to reduce the risk of overdose occurring. And very importantly here, you have the opioid agonist treatment with the need of retention and a continuity of care to prevent overdose. And at the end, you've got the level of intervention that aims to reducing the fatal outcomes if an overdose occurs. And here there are interventions that we have in some countries, like drug consumption facilities. But today we focus on the left, which is naloxone administration and naloxone distribution and training by specialist services, first responders, and in the community in general. So where are we with this particular intervention at the moment in Europe? What you can see here is the number of European countries implementing the harm reduction interventions up to 23. We've published this report in June 24. If you see the yellow line, it's take-home naloxone. You see it started in 2010 in Europe, and now we've got about 16 countries who have implemented these responses. It's not easy. It requires lots of work, and I think the colleagues who will talk after me will be able to illustrate that. Think about Meteja, for example. It requires pilot programs, feasibility studies, national adaptations, but that's where we are now at the moment from a European perspective. And as you know, the situations are very different because there are various formulations of the medicine, so different choices can be made. There are various scales and modalities of implementation across the countries. And there are some possible barriers that have been really identified and discussed with the stakeholders, the experts, the professionals. That can be about inadequate training, time constraints, the cost, the reimbursement issues, and the stigma that can in the naloxone service implementation. There's a need for research and into the health outcome of the program and into their implementation, and that applies to any medicine and to any health program. And importantly, there are some differences between community and prison, and that's a gap that has been identified. If I just show again this situation of the take-home naloxone in the community, we see that we have 16 countries, they are in green in the map, where there is naloxone, take-home naloxone in the community. But then if we think about the prisons, it's far less available, and it's important because you see this WHO post there reminding us that prison health is an integral part of public health, and that protecting people in prisons means leaving no one behind. And that brings me to the last point of this talk, which is about for preparedness, because about prison, you know that there have been some deaths and some poisonings in England in 24, and I just show you here this overdose linked to nitazen in prison in Ireland in July 24, and it happened as well in France in the La Réunion Island in 23. And these nitazens, as you may have heard about, they are actually these very potent opioids that are really changing the situation in the opioid market and the level of risk associated with opioids. So that's about prison, but actually these nitazens, and in some countries it's about fentanyl and carfentanil, these highly potent opioids are there. And we've written actually a communication, a letter on nitazen representing a growing threat to public health in Europe. We did that with some colleagues in the agency and with the national experts from Estonia, Katria Bellolo, and as well from Latvia, Diana Vanaga. So we were able at the time with these colleagues to put together the number of deaths, to see how the numbers were increasing and how much these strong opioids were actually driving the increase in the deaths in their countries. And the conclusion of the paper was that we would add that we cannot assume that existing approaches to responding to opioid problems will be sufficient without adapting to the challenge imposed by the appearance of a range of highly potent but pharmacologically diverse substances. So that brings me to this last slide where, again, reflecting on preparedness. What you may see on our website is that a multifaceted response is needed to prevent overdose deaths, as there is no single or simple intervention that will make a large impact alone. So there's no magic bullet, but it's really about integrating responses. That means provision of large-scale opioid agonist treatment, promoting quality of the care in treatment, and implementation of interventions supported by evidence, and provision of harm reduction interventions. That's where the naloxone fits. And importantly, provision of drug treatment, including opioid agonist treatment in prisons. And finally, to develop the national overdose prevention policy supported by long-term commitment from policymakers and funding for treatment services. And I just finished with these keywords of the new mandate of our agency. It's at the top of the slides. It's really about anticipate, alert, respond, and learn. And I just wanted to say, right today, I'm sitting in the building that is just behind the learn. And we're here in Lisbon, and we hope to see you very soon, actually, in Lisbon at the Lisbon Addiction Conference to be held in October. So I thank you very much for the invitation again, and that was it for my intervention today. Thank you.
Thank you, Isabel. Very informative, and also, like you mentioned by the end of your presentation, there is so many things on the webpage of EUDA where you can find a lot of different information, including also some videos on YouTube channel and everything. So there's much more available, which we can use and search for. While we solve the problem with the video, I would invite now our colleagues from Villa Marini, Philip Garcia and Nadia Gasbarini, who will make presentation about their work. Villa Marini is an organization which launched, which is actually behind the good cooperation between with the International Federation of Red Cross, and they had a lot of work in countries, developing countries. And also home in Rome, they administrate a very good and very effective Naloxone program, which those who have been in Villa Marini had the opportunity to see. And it's really very good to hear their experiences, because they had all this kind of hands-on experience on providing Naloxone directly on streets. Okay, Felipe, you or Nadia?
Thank you, Milutin.
Thank you, Milutin. Good evening to you all. Can you see my screen, my presentation? Okay, thank you. So, like Milutin already said, let me see if I'm not article. Sorry.
Not moving on the other slide. How to go on with the slides?
Wait. Sorry, guys.
If you switch to PowerPoint.
Yeah.
Okay, sorry. So, the Villa Marini Foundation started in 1976, so more than 40 years ago. The center was opened by Dr. Massimo Bara, who is the former president of the Italian Red Cross and the former president of the Red Cross Red Crescent Standing Commission. We applied 7 Red Cross Red Crescent fundamental principles in all our activities. Just a few words on who we are before we enter the topic, because mostly we work in the field. We don't do a lot of theory here. And so we are the reference center on substance abuse for the International Federation of Red Cross Red Crescent. We are also the national agency on substance abuse for the Italian Red Cross. For us, this is just a little bit of our philosophy. For us, abstinence is not a precondition for treatment. I mean, with that we treat each individual as a unique entity and also active drug users. And you don't have to be drug-free to enter our services. And we provide a wide range of possibilities from low threshold to high threshold level for around 600 people who use drugs every day. This depends. And we apply the continuum of care concept. That means here I just put the most important services we provide here in the foundation. So in the low threshold services, we have the outreach units and the emergency unit. In red here, because they are part of the services where we use a lot the naloxone. We also work inside the prison. Then we have the low tracer services. We have an orientation center where people who decided to undertake a program can start to think about what they want to do. We have a drop-in center, a classic drop-in center. We have a different level of night shelters. It depends on the fact that if people are active or not. Some night shelters are for the drop-in center, so they are active. They are separate from the night shelter of the high-level services. We have an ambulatory, a clinic service where we provide mostly methadone every day to around 200, 300%. And we have the high-level services who are communities, at least. We have the semi-residential rehabilitation program where people stay just during the day. We have the full residential rehabilitation program where they sleep. They stay there 24/24. And we have also an outpatient rehabilitation program, mostly for people that cannot quit their job to undertake a program like the first two ones. And for us, the continuum of care is that the people can move up and down through all the services according to their need and capacities. And for example, if someone is in the semi-residential, relapse, he can go in the full residential maybe, or if he relapse also in the full residential, he can go back to the orientation center and so on, up and down. This is to leave no one behind. Because, you know, addiction is it's a long disease. It's a very long disease to treat. So the 3 units, we all know that.
Well, at least I can see on your first slide. I don't know if others can see it. Maybe.
You can't see the slides?
We see only the first one, the introduction slide.
Why? Like the lady before. This is very strange. Wait. Non capisco.
How can we do to move from one slide to
I'm
another?
trying to go out of the.
Maybe you can go to the presentation, kind of to PowerPoint, and then from there just change the slides.
Quindi non dal Zoom, ma dipende proprio dal desktop.
Nuova condivisione. Desktop.
No, senza condivisione. Chiudi, esci e lo fai direttamente dal portale, loro lo vedono.
Thank you, Milutin. I was going through the. You can see it now? No.
Sposta?
Condividi.
No, lo devi fare da là, capito? Perché tanto la condivisione non sposta di qua.
You can see it now?
Just the first slide.
The first one, yeah, okay. Now you can see the second one?
Now it's okay. Yes, now it's
Oh
okay.
my God, technical issues. Anyway, this is what I was reading before. I will not repeat it, sorry. So the general info, the concept of continuum of care. And I was here in the 3 units. So I will focus only on the units where we use naloxone. So we have two street units. For us, it's a way to reach people excluded from any kind of treatment. To reach people that are out of the national system. The 3 units are in the suburb of the city, where there are these big markets open 24/24, and mostly there we do needle exchange and overdose intervention. It's also a way to have a daily contact with this kind of people, to reach them every day in order to build trust and then try to help them and provide more assistance if they ask for, of course. And it's the best way to enter in contact with the most problematic drug users. So we do overdose intervention there. You can see on the picture there is the team, and there is a big square there. So people buy heroin not far from this place, then they come in the camper to ask for clean materials, and they inject on the sides all around the camper. So because they feel safe, and if there is an overdose, they can call our outreach workers that can intervene on the overdose. Also, the police know this place, and there is a kind of not written agreement with them, but they just pass, they never stop. So it's, let's say, a kind of outdoor shooting room, we can call it like that. And so we use naloxone. We use syringes. We don't use nasal naloxone, mostly because nasal naloxone is expensive. The injectable naloxone is
Much cheaper.
is much cheaper, and we are used to use it since 1990 or 1980. I don't remember. And 90% of our staff are all former drug users because they speak the same language. And actually, they know better than a doctor how to use to inject naloxone in people, you know. We also, naloxone is not, I mean, it's without prescription in Italy. So we also distribute naloxone, take-home naloxone. If there is an overdose, we always give naloxone to the person when he leaves, of course. And we distribute naloxone also to the families because for us, it's important to, when you have someone who uses drugs in the house, always have naloxone in the house, because you know better than me that a lot of them die in the bathroom or in the room alone. So, and sometimes when you find your son in the bathroom, it's too late to call the ambulance, and so you have to have naloxone at home. We also, of course, distribute condom and provide counseling. So yes, needle exchange program. We give clean materials and we collect used material, and we do also HIV, HCV rapid tests on the streets, and we have a linkage to care with 2 hospitals in the city, because when tests are positive, it's very important to have an answer, not only give a response, you're positive, but we physically bring the person to the hospital. We have special team that bring the person to the hospital to assessment and start the treatment. Street units, and emergency units. So the emergency unit is also for overdose. It's a free phone number, open 24/24. They call us from all the city for all kind of problems, also violence in the house, every kind of situations, also for overdoses, of course. We have this medical car that can go all around the city, but mostly we have this deal with the police and the carabinieri. They call us when somebody is under arrest and in withdrawal crisis in the police station. They call us and we go in the police station to provide methadone to the person under arrest. So the person under arrest can, let's say, be better and quiet, and the police can sleep. You know, when you are in withdrawal crisis, it's very, very, very bad, and it's very, very bad also for the police, for the officers that work at night with this kind of person. And then we go the day after also to the Court of Justice to bring another dose of methadone in order for the person under arrest to be able to talk with the judge and not being in withdrawal crisis, because he will not understand what's going on, you know. So so this is for the services we provide. Just to go back in the 1980s, so Dr. Bara was the first one of the first in the world to conceive and then implement the use of naloxone in the streets. So you can see it's very long time ago. Also, the word harm reduction was
not used.
Not used yet. It was not allowed to say harm reduction in UNODC, and civil society was not in UNODC. Now the situation is completely different, but I like to say that Mr. Bara had a kind of vision. And in the 80s in Strasbourg, they had this meeting with a Red Cross group of experts on addiction, and it's interesting to read in the statement that the Red Cross movement asking to study the possibility to include naloxone in the Red Cross first aid kits and train Red Cross staff and volunteers, because naloxone is a life-saving medication with an excellent safety profile and rare incidence of adverse effects, then easily usable also by non-medical trained figures. When I was talking about the street units, I've told you that 90% of the staff are former drug users, and they do overdose. There are not medical staff. but they are trained and they do overdose.
Intervention with naloxone.
Intervention with naloxone, and I will show you this after. This is just a screenshot of the statements. It's just, I mean, just for the story. And then, according to our experience, people at risk of overdose are at risk of overdose for a lot of reasons, but the main 5 reasons are: the first one, when they finish a program, a rehabilitation program, especially when it's a closed program, okay, they are in the community for, I don't know, 1 year or something like that. They go out, they relapse, and they overdose because they're clean. The same reason for people that come out from prison. They relapse and they overdose because they're clean. Also, poly drug users, we can see that, especially in the youngest, they use a mix of everything. And they are more at risk of overdose because they mix. Yes, I wrote also new dealer, because when you change dealer, you don't know the quality of the heroin you're buying. So you are at risk of overdose, and also occasional consumption. We have clients that take heroin just once a week, and they change dealer every week, and sometimes they overdose. So practically, how to recognize an overdose? First of all, the blue coloration of the skin, especially in the face, it's dark blue. And this is because the person cannot breathe well or cannot breathe anymore. And there is no response to stimuli, no response. So those are the three, let's say, first things to check when somebody is down in the floor. How to use naloxone? Maybe you all know that, but it's not. I mean, it's important to repeat it. First of all, the immunity is 20 minutes, so the person can go back in overdose after 20 minutes. So you should need more than 1 injection, and when you do the naloxone injection, you have to keep the person with you, with the staff, at least for 1 hour. And after 20 or around 20 minutes, if the person go back to overdose, you have to do another injection. So because naloxone, we all know that it's an antagonist, we call it an antidote at least, that has no collateral effect. So coming back to the poly drug users, the people who mix all kind of drugs, if it's not an overdose, if the overdose is not the problem, there are no collateral effects. So also, if it's only, I don't know, if the person is drunk or he mixed alcohol with, I don't know, everything, if you inject naloxone, you will have no collateral effect. We start first with an intramuscular injection, also through the clothes, through the clothes, because you don't have time, okay? Then intravenous, if necessary, after a few minutes. Anyway, it's when you do the intramuscular injection, after 1 minute, you should see the difference. Just the color of the skin change. If not, you can do another one, and waiting for the reaction of the person, you should start to search for the vein. And here it's a problem because if it's a young person, the young people still have good veins, so it's not difficult to find a vein. Older people have for older people, let's say that it's more difficult to find good veins for naloxone injection. So you have to do more, several muscular injection or under the tongue, but this is a very sensitive way to do it. You have to know how to do it. There is a way to do it under the tongue, but it's very sensitive. Yeah.
Just to clarify, this is the protocol that we have developed in more than 25 years of experience of doing overdose intervention in the street. So this is the protocol that is used by our outreach worker in a case of overdose in outreach setting. So in the street, in the park, in a very, I mean, complicated situation, not like in hospital or in in ambulance. So just to clarify this.
So the services, what we do, overdose, just want to show you a research that we made with the University La Sapienza here in Rome to talk just to talk about the cost effectiveness of naloxone. So we compare 90 overdose interventions provided by our street unit and the Italian National Health System, and at the end we successfully treated all overdoses, and the cost for each intervention is 7 times less comparing to the National Health System. So the conclusion is that the treatment of opioid overdose in the street context offers a safe, cost-effective strategy for the reduction of opioid overdose-related death. So it's cheap. It's cheap to do. Siamo in call, scusami. It's cheap to do. It's cost-effective, and it works. And just some data. We start to collect data in 1992. So I can say that we made more than 3,000 successful overdose interventions made by non-medical staff since 1992. And we also have on our website and also in our YouTube channel a short 3 minutes video tutorial on how to do an overdose. I will put you the link in the chat box later, but you can find it easily on the website. And I don't know if Nadia wants to add something.
No, you say everything. Just to say that besides this video tutorial, we have also like some publication on our experience.
It's the contrary. You cannot.
Our experience with naloxone in overdose intervention that also you can find on our website, or you can contact us if you want to have this information. These are our email addresses.
You have our emails, and this is also our slogan: stigma kills more than drugs. That's it. From practical side, not theoretical.
I don't know if you have questions.
Thank you.
There are questions for us.
It was really a good presentation of practical work that people are doing. Just to say that when I was in Rome, it was May last year for an event. The emergency unit gave 11 shots of naloxone to a person to save his life, and the last 4 were under tongue. So sometimes it's so critical overdose that naloxone even is not enough, or you need to use a lot of it to save life of people.
Yeah.
Thank you. And now I know that our next speaker, Mateja Jandl from the Slovenian Institute for Public Health, is kind of in a rush because she has to leave relatively soon. So I will give floor to her so she can do the presentation. Just also to say that Slovenia for us in Southeast Europe, especially in the ex-Yugoslavia countries, is always kind of an example of kind of developed system of something. So we always like to listen and to hear and to invite them to tell us their success stories, because we can then easily copy them and use in our own setting. Please, Mateja, go on.
Thank you for this kind presentation of our work and our country. Yes, we are always happy to present, as we were once together in the same country. So thank you for this invitation. I presented a short overview of situation in Slovenia. So what was how was our way to be successful in achieving this implementation of this of health naloxone in Slovenia? But first, maybe just few data. Do you see my next slide? Okay. So these are the data from 2022. We can see that in Slovenia we had 66 deaths related to drugs. The mean age was 44 years, and the trend began to go down from 2020, but I have already this data for 2023, and unfortunately the trend goes up again. So when we take a look at mortality rate in European Union, we can see that it's 22 deaths per million population, but in Slovenia this number is much higher, it's 46, so this is really a concern for us. Also, the age distribution is now really in the age group 45 years plus. So we know that users that are older, of course, have more health problems. So they are really more in danger to make overdose. And also the toxicology of those deaths, we can see that 3/4 of deaths in Slovenia were those where opioids were mentioned. In Slovenia, we really have a good coverage with treatment centers where substitution treatment is delivered. So we have 21 specialized outpatient centers and also 2 mobile units. And so the users, there are around 3,000 users that receive substitution treatment in Slovenia, also around 100 in prisons. So we are quite proud of this network. And when we were thinking about implementing take-home naloxone in Slovenia, we had in mind that we have this good network in Slovenia. So our idea was to go and mobilize this network. So let me show you how our story began. So we created, or we gathered, we made working group, and so in this working group it was me and a colleague from Focal Point. Then there were colleagues or employees from Ministry of Health, Health Insurance, Agency for Medicinal Products and Medicinal Devices in Slovenia, and we also have 2 representatives from non-governmental organizations. We had several meetings with Health Insurance Institute of Slovenia, and I can say that we were really obviously pushing and we were so successful that in only a year and a half we agreed with Health Insurance that nasal naloxone Nixoid will be covered and will be paid by the Health Insurance of Slovenia as part of substitution treatment programs. So all the users that are in substitution treatment programs are can receive naloxone there, and this is for free of charge, so costs are covered by the Health Insurance Institute. So with this, nasal naloxone is available in Slovenia from March 2021 and can be distributed, but Nixoid is also available through prescription, and any physician in Slovenia can make or give prescription for Nixoid, for nasal naloxone. But in this case, users or persons have to pay for those two, for one kit where 2 shots are, and it costs 28 euros. So we made this intervention through a network of these 21 treatment centers, where also training and distribution of naloxone now take place. So users get naloxone in hand. And I wrote this down. What about relatives? We know that take-home naloxone is intervention where actually relatives, friends, witnesses will use this naloxone. So if a relative or a friend would come to this treatment center in Slovenia with a user who is receiving substitution treatment in this center, usually it would get also a kit of naloxone, but this is more like where some centers are more keen to do this, some centers not. So, yes, users get it. So when we reached this agreement with insurance company, we prepared national recommendations. This was our colleague, Dr. Andrej Kastelic. I think many of you know him. He prepared national recommendations, and also we prepared training protocol. And then it was him and me. We were kind of national trainers to train the medical doctors and nurses, and also we trained staff in prisons to start this training process also, so that now medical doctors or nurses in those centers are trained to give training to the users. Yes, you all know that take-home naloxone isn't just handing out the naloxone, but it must be done with overdose education and first aid training. So now the users in those centers in Slovenia get to know how to recognize signs of overdose. They know it is important to call for help, how to administer naloxone, or if it's necessary to offer airway relaxation, and also to stay with a person who has experienced overdose. So those trainings, as I said, are done by nurses or medical doctors in those treatment centers. We all know that it is stigma or fear of calling for help. That is sometimes the biggest obstacle. So in those trainings, we also like to, or we address this problem. So yes, I think it is more and more obvious that when this program or this take-home naloxone intervention was introduced in Slovenia, we also informed police officers about this, so that they really know that with their attitudes, they try to reduce the stigma or fear of calling for help. What are our problems? So yes, what we experience now are concerns from medical doctors. Their concerns are about where will this naloxone end? So we know that this naloxone will not be used by this person, but maybe also not by the friends or relatives of this user, but that this naloxone will have its own way. So their concerns are kind of legal concerns. If something will happen or a person will die, and there will be a possibility that this naloxone wasn't implemented in the right, or not implemented, not given in the right way, if this is something that they could have problems with. Then we have problems that users have to ask for naloxone. We know that it's better when it's top down, so that the medical doctors ask users, are you willing, or would you take, or do you need naloxone? So this is also something that we have to improve. And of course, we don't reach hidden population. We give naloxone also only to users who are in treatment center, who receive substitution treatment. But we know that there is population that don't go or don't use substitution treatment. So we somehow didn't find the way yet how to reach this population. We want to make evaluation, of course, through the questionnaire for personnel, for medical doctors and nurses, and also to get self-report or experiences of users who will return for next naloxone. We will ask them, or we try to ask them, what was their experience? Did they use naloxone, or did they have in this situation when overdose occurred? But unfortunately, I must say that we already have 3 years now of this program or this intervention, public health intervention. But I can tell you that in 2023, this is the last data, only 140 kits were delivered, but our plan was to deliver around 2,000, at least 2,000 kits. So we are not there yet. I can say that the data we get from pharmacies, as I mentioned, also any medical doctor can prescribe naloxone, and we know that around 250 or almost 300 kits were prescribed against payment or for payment. So people also buy naloxone in Slovenia, but again, this is not a high number of kits that were sold. So our plans are to widen our access is to, of course, to give naloxone to police or customs service. I can say that we get a requirement from customer officers to be able to have naloxone with them, because they are afraid when big shipments of maybe fentanyl would occur, that they would be in danger of overdose. So we are in with our colleagues from Ministry of Health, we are in a process how to arrange this distribution of naloxone between police officers and customs service officers. But the problem is, of course, also at the EU level, that naloxone is a medicine, is a drug, but that has to be prescribed and delivered by a medical doctor. So it cannot be prescribed or delivered by an NGO or maybe by our institute, National Institute of Public Health. We must have a medical doctor that prescribes or gives out this drug. So these are kind of legal problems, and we don't find the real legal base to be able to make this next step. We also would like that we would have naloxone when maybe outbreak would appear in Slovenia with fentanyl, or our biggest achievement would be that personnel in non-governmental organization would be able to deliver naloxone. But when we will overcome these legal barriers, we will let you know. So this is from my side. I apologize. I was in a hurry because my colleague was already in this room and have also online meeting, but now she left, so I can stay with you and also answer some questions if there would be some questions. Thank you.
Thank you, Matea. As I said, it's always interesting for us from the rest, the other countries in the region, to listen to your experiences, because all this process of getting people together and discussing is something where we are at the moment, and it will be very useful to know what are the challenges and what are the good things which help that you come to a certain point of success. Very, very informative for us. So now we go to Scotland. Wiz is with us. He is part of the Scottish Drug Forum, which is kind of a big organization working in this part of the UK. And we know that they have these good results, and it's nice to have Wiz with us. They were also distributing a lot of syringes, a lot of doses of naloxone, and I heard, actually, I think most of us heard for the first time of something about naloxone, and kind of, especially about community distribution of peer naloxone distribution from the Scottish Drug Forum back in 2017 on a harm reduction conference in Vilnius. Please go on.
That's brilliant. Thank you. Sorry, I lost my controls there for a wee second. Hopefully, can someone give me a thumbs up that you can see the slides? That's brilliant. That's awesome. Thank you very much for the invite. So yeah, my name's Wes Steele. I work with the SDF. Thank you for the invite to come along and speak about peer-to-peer naloxone supply in Scotland. So just a wee bit of the background, I guess. So people probably know the medication was first patented back in 1961. We had one of the first national naloxone programs, which initially allowed drug services only to supply kits to people who are engaged in treatment and support with them. And the program provides training on the use and trains people to train others. So there's a few different levels to the training. I usually talk about like the basic awareness session. You can get trained to use a kit in about 10 minutes or so. And then we do the kind of training for trainers to teach people to teach others. So it's set up in 2011 to allow people at risk of an overdose to have a take-home kit. While that's an amazing start, if I'm the person at the greatest risk of the overdose and I'm the only person that can have a kit, who is going to use it on me if no one else knows how to use it or even where the kit is? So we very much welcomed the law change in 2015 to allow naloxone to be supplied to anybody likely to witness an overdose. And I would argue in Scotland, and you'll see I've got a couple of graphs coming up, that literally means anybody. Unless they live on an island on their own, they are likely to witness an overdose, although they might not recognize it if they haven't been previously trained. During COVID, non-drug treatment services can also start supplying kits. I really welcomed that change. I used to work in homeless accommodation. We would have kits to use on site. Lots of high-risk residents leaving the service to go and score drugs and use. We were unable to give them a kit to kind of take with them. No Good Samaritan law in Scotland, but it is legal for any person to administer naloxone to any other person for the purpose of saving a life. So as long as they're administering appropriately, they'd be legally protected. People don't need to have attended any formal training to actually intervene in that emergency situation, although we obviously want people to be trained up before they're kind of getting a kit. But if someone came across somebody, they would be legally protected to just intervene. Why do we need it so much in Scotland? Our drug deaths are out of control. We've just had more stats published just a week ago, 1,172 drug-related deaths in 2023, 80% of those involved in opioid, more than double from just 10 years ago, and you're 2.7 times more likely to die in Scotland than you are in the rest of the UK. And unfortunately, people on the ground are telling us things are not improving. We almost anticipate an increase maybe with the synthetics entering the market and the kind of increase in the toxic drug supply. These are accidental, but therefore then by definition, that means that these are preventable. And I would argue in the vast majority of these tragic preventable deaths, if someone with naloxone and the ability to use it had been present, the chances are they might have survived that. So 1,172. Tragically, I know some people that make up this number, and I'll know some people already that will make up the number of deaths next year. So that's why we need to have one of the best, hopefully, kind of naloxone programs going, because we're up against this. bit of context, lovely to see so many European partners on the meeting. This is where Scotland's sitting in the table in comparison to the rest of Europe. I moved to Scotland about 7 years ago. I had no idea how much more significant the drug deaths were. I moved up just from England. So yeah, just for that kind of context and that background. Why a peer supply? So I've already said that opioids dominate the drug deaths. Synthetic opioids are now emerging, increasing that risk of overdose. And I would argue that peers really do have privileged access. They have an increased risk into the most at-risk communities, and they have instant credibility. The amount of people that I have seen offered naloxone interventions and just decline it because it's coming from a clinical or a kind of professional support worker or caseworker, whereas somebody from a similar background might have had a similar shared experience of using similar substances, they've got that buy-in almost immediately is my opinion, I guess. So within the most at-risk communities, I would argue it makes them really well placed to improve naloxone provision. A wee bit about the project. So we were initially funded by the Drug Death Task Force back in 2021, building on some of SDF's earlier work from 2017, which saw the first Glasgow-based peer-to-peer naloxone training and supply pilot. All models prior to that were just an education model where the peers weren't able to actually physically supply the prescription-only medicine themselves. So we welcomed that, and we've been building on that earlier work. So just, I guess, to acknowledge that. So we initially had a budget for 9 projects from the task force funded work. And that also included 1 day per week of partner staff time and 40 hours per week for the community projects of sessional payments for the peer suppliers. So again, this is one of the first times, to the best of my knowledge, that the peers involved are being paid for their time and their expertise. So our 3 key objectives were to establish, embed and support a high quality peer supply of naloxone as a core service across Scotland, ensure those peers have an active voice in the delivery of that intervention, but also hopefully helping to inform other harm reduction strategies, and then to create a national network and try and offer unfunded support to anyone in Scotland who wants or is doing peer-to-peer naloxone stuff. So that's a wee bit about the funding and the kind of aims of the project. I won't go through them all because just in the interest of time, but some of the earlier stuff and some of the highlights, I guess, of some of the earlier kind of projects we did, which spanned from 2021 to 2024. The third sector partnered in Scottish Borders. They didn't have a specific kind of job role for someone with lived experience, and that sparked the creation of that job role. We had an open invite for the peer naloxone champions to be invited to the locality harm reduction meeting to help inform and, you know, even bring in some insight into some of the trends and things like that. Dundee was another community project. So in a year, 36% of all Dundee supplies from 2021 to 2022 were made by a team of about 5 peers. All the peers were retained. All the peers went on to much more substantial roles. And I'm actually delighted to say that one of those peers, about a year or so after that had wound down, has actually joined us now in a national role, helping the kind of national rollout of some of that work. So that real progression. The 3 Glasgow prisons. So we initiated first in HMP Ballini, groundbreaking project. To the best of my understanding, the first time a resident or prisoner in a prison can train and supply a prescription-only medicine to another resident in prison the night before liberation. So really, you know, minimal staff involvement. The staff take the kits and the paperwork to the halls. The peer collects it. The peer approaches the person due to be released. There's no kind of staff involvement at that point where we've got that coverage, and it's quite difficult to keep that kind of rolling training program. But that project's locally resourced now. They've kind of really embedded it and kept it going. Fife, we saw 450 kits go out in Fife. Fife's quite a rural area, a bit of a wider spread, less kind of active service provision or visible service provision, for want of a better phrase. And the ADP have funded a smaller scale continuation of that. We've partnered with a couple of non-drug treatment services and a homelessness service up in the Highland as well. And then some of the other work you can see there. So down in Dumfries and Galloway, peers went on to do some dry blood spot testing and things like that as well. And the Scotland's only open prison, Castle Huntly, we actually have seen some residents there doing training and supply on their placement. They might be, you know, doing volunteering as part of their community access. So they're living in a prison, but they're coming out and they're actually doing some of this harm reduction work out in the community. There's some links on the slides to a webinar and to also us speaking at a conference on some of the work as well. We might have been able to provide a bit more detail when we've had that wee bit kind of longer. But that's the kind of first phase, if you like. That's the Drug Death Task Force funded work. Then we've now been funded by Scottish Government. So we're kind of core funded for the rest of the Parliament, if you like. We don't hold the budget now, unfortunately, for the sessional payments for the peers. But I've got an additional post has joined me, and we've got a strong emphasis on trying to roll out to all the prisons. And we know how much more at risk people might be, you know, after being incarcerated for a short period of time. So we're trying to kind of do that. We've expanded to HMP Perth. They launched back in February. We do still support and offer to help set up any community work as well. We've just got that kind of slightly stronger focus. So they're all the projects that are kind of planned or that are up and running at the moment. We're also delighted to be interviewed and have a reporter from BBC World Service come and do a wee news piece on that. So there's a link there to that as well if you're interested. It's more of a podcast. I think it's only about 20 minutes or so. Just some numbers then. So putting the work in, my favorite part of all the work, all the planning and preparation, we know we need it. We need the policies and stuff in place, but it's actually hitting the street and getting out and speaking to people. The two chaps in the middle facing the board there, that's actually in the hub in HMP Bellini. So they're kind of doing an awareness raising session. The picture next to that, the then drugs policy minister came and visited us at the kind of wind down of the Castle Huntley project. And you can see me, I can't remember what the joke was, but kind of laughing with one of the police officers there. We're very fortunate in Scotland. All forward-facing officers now carry nasal naloxone, and they've used, I believe, some 500 odd times since that kind of rollout. Just on the stats as well, before I bring up the kind of totals, Public Health Scotland published quarterly naloxone data, and for the most recent quarter we've got data for, 41% of all prison supplied kits were made by peers, and we're in less than half of the establishments up to this point. And 4% of all community supplied kits were also kind of made by peers. But all the work we've been involved in, we've seen just shy of 4,500 kits go out. Over 3,000 of those were first ever supply. So again, I would argue we are reaching people that are not routinely being offered. You know, we've only got about 40% of people with problematic drug use in Scotland engaged in treatment. And a previous speaker spoke to that kind of population that aren't being reached. So I think we are hopefully trying to reach those. And we've seen over 5,500 peer hours worked. 4,000 of those hours were on the community projects that were funded, and peers were all paid for that work. You know, we struggle to always get peers paid in the prison setting. Some peers have actually opted to volunteer as well, just because they didn't want the benefits implications and things like that. We have created a couple of national networks. We've got a national peer naloxone network for peers only. So kind of conventional staff or coordinators, managers, etc. aren't invited to that. That's a bit of a safer space for peers to just share any frustrations or challenges. We have a standing agenda item from the RADAR service, which is Rapid Action Drug Alert and Response Service. They share data on emerging drug trends. They also ask the peers themselves if they're seeing a difference in the drugs that are being used kind of on the street. So it's a two-way conduit that we can feed into. We've had 12 quarterly meetings of both networks. We've got a diversity of partners across Scotland. We get invited speakers and we ask the network who they want to hear from. Then we do area updates and sharing practice and learning. We've got an MS Teams channel with over 200 participants on. We use that for sharing reports, sharing resources, making connections locally and things like that. Some of the learning so far, unfortunately, I do think there's still sometimes a bit of a reluctance to employ people that are still using illicit substances, or even in some cases people prescribed OST, which I always find a wee bit baffling. You know, it's an essential medicine. It's the gold standard for treatment for opioid dependence, but sometimes it's a barrier then to employment for people. PVG, so that's the kind of protecting vulnerable groups, or the criminal records checks, if you like, for people working in third sector services. That is a real issue for people. Short-term funding, all our Drug Death Task Force work was fixed-term funding for a year. Many of them went on for 18 months with an underspend because of the kind of lead time for recruitment and the kind of delays for recruitment and things like that. In the prison settings, it's often access and time constraints. If things happen operationally, peers don't always get out to go and offer the intervention to people. So that's a real barrier, you know, limited power of or control over kind of overcoming that. Some of the facilitators, we've seen in some areas and some organizations a real progressive approach to recruiting people who do use drugs. And I always I'm an advocate of, can people do the role? Why are we talking about substance use or not substance use, or prescriptions or not prescriptions? If people can do the role that we're looking to recruit to, then they should be eligible. A proactive coordinator with real good local knowledge is really essential, in my opinion, for getting these projects up and running quickly. Widely advertising the peer role, doing some of the remedial work around benefits concerns and things like that, doing some myth busting around, you know, people can work, people can go on permitted earnings and things like that. I should also mention that the 3 earliest projects to launch from the task force funded work were formally evaluated with partners from Glasgow Caledonian University and SDF peer research team. So that's been published. There's a long and a short form of that going forward. And just to kind of get ready to sort of wrap up a wee bit, I would argue, is the sky the limit? You know, where we've got this happening and peers are successfully improving the naloxone provision, can we use that reach, that credibility, and that identification with people for dry blood spot testing, injecting equipment, even wound identification, signposting? I mean, if it's resourced and funded and run adequately, I would suggest that the sky really could be the limit. An external partner has just very recently got approval. They've been doing peer-to-peer naloxone supply for about 5 years or so, I believe. They're now doing IEP. So they're in Edinburgh. I live in Edinburgh. They're actually now able to give out injecting equipment to people on the street when they're seeing them. And again, that peer-to-peer kind of approach is really paying dividends. I would argue embedding peers within existing staff teams really does increase the skill mix. I think it can sometimes bring a different attitude or approach to things, and it can improve responsiveness to this ever-changing drug trends that we're kind of up against. So again, we've seen some really good outcomes for some of the peers. We've had peers then, after being involved in the naloxone work, join us on the national traineeship, which is a 39-week project. They get a qualification, and most of those then will go on to kind of work with their placements or their kind of other employers in the area and things like that. So always looking for new opportunities for peers where the funding has been fixed term. I do apologize. I do move at 1,000,000 miles an hour. I think I had about 10 minutes. Hopefully I haven't run too far over. But yeah, open to any questions or to hang about for a wee bit, and happy to link in and share some resources and stuff too. But I will stop sharing, and I might chuck a couple of things in the chat if that's okay.
Thank you, Reese. I think it's well, I have to say, I thank you for not speaking really Scottish, because it's sometimes not very easy to understand fully the people from Scotland, you know. But it was always that you have a lot of things to say, and we are kind of, whoa, so many things coming in. So it's been good, and I'm quite sure that we will share the presentations you gave to all the people and put them on our webpage. Also, there was a question about the recording. It will be there on our webpage, so people then maybe go slower through it and try to see deeper into some things. And this is something really, very, very interesting. Obviously, something which is far from us in the region, but sometimes is, as we said, that the sky is the limit. You know, so we can dream about a very, very quality, high level, very spread program going on, but we will start from the first step to reach it and have it in our minds as a kind of a final target. Okay, so we will try now to see how we can maybe we should hopefully have the recording. I had a contact with the person from UNODC, and there is a potential that they will let the recording on. Is that possible? I can try again to do the thing, but I'm not sure if it will work at the moment. So, not Matea, but Maria Augusta, if you can maybe try to.
I'm trying now to share my screen with your recording.
That would be good. Because it's a presentation of a program which worked very well in eastern part of Europe and Central Asia. So also for us, something which is kind of probably similar setting, and it will be good to have it. Yeah, that's it. Okay.
Distinguished participants and dear colleagues, dear friends, thank you so much for having me here with you today, at least virtually. Unfortunately, I cannot be there with you in person in occasion of International Overdose Awareness Day, a day in which we honor the memory of those people who use drugs and people with drug use disorder who lost their lives to overdose, and the grief of their families and communities. And we remind ourselves that there is a lot that can be done to prevent such deaths in future. And in this context, I would like to share my presentation with you today. I have a few slides. I hope you will find them of interest, where we share our experience in providing emergency management of opioid overdose through the UNODC WHO initiative that we called Stop Overdose Safely, SOS. I think that global situation is known to all, but it bears repeating. Worldwide, we have the new figures from 2024 from the World Drug Report published by UNODC. There are 64 million people living with drug use disorders, a figure that has been increasing by 3% over the last 5 years. And as unfortunately is often the case, also we know that there is a large treatment gap. So only 1 in 11 of these people with drug use disorder has access to treatment. And we know that the situation is much worse for women. So we have only 1 person among women who is in treatment, while 1 in 7 of their male counterpart is in treatment. So of course, we need to work hard to close the treatment gap for everybody. This is also because the deaths related to drug use disorder continue. Here on the slides, you see deaths related to drug use disorders, mainly overdoses, and mainly what you don't see on this slide is, of course, overdoses due to the use of opioids. And then, of course, that's directly related to drug use, such as liver disease, HIV/AIDS, and self-harm. These are many more, especially within these, liver disease is particularly prominent. But what is particularly tragic in general about all of these deaths, but the ones due to opioid overdose in particular, is that they are very, very preventable. And this does not need to happen. And this is a part of the work that we are doing worldwide through the UNODC WHO program on drug dependence treatment and care to disseminate evidence-based and effective services for the treatment of drug use disorder. And I say treatment, but of course, I'm covering something very, very broad. And I'm covering an evidence-based continuum of care that encompasses outreach, drop-in, outpatient, inpatient, long-term residential. And in here you see that we try to picture all of these settings and possibilities. And of course, here you have very strongly outreach to support people who might be even experiences a suspected overdose. All of these services are necessary in a well-functioning system that protects and promotes the health of people who use drugs and people with drug use disorders, and of course also promotes, if they so wish, their recovery. This is all in the standards. And we have been having the honor to work with Serbia, with your country in the past. on this very issue. We were very, very happy and fortunate to include a national policymaker in the training on nature, prevention and treatment of drug use disorders to inform evidence-based and health-centered policies, and to follow this up with work on quality assurance, so assuring the quality of the treatment of drug use disorder systems. What I would like to present to you a bit more is our work on overdose. And of course, we work together with the WHO, and we take as basis the guidelines. First of all, we presented a discussion paper together with WHO, which was focusing on the effective measure that we knew until then, which was providing access to effective treatment for people with opioid dependence. Opioid agonist maintenance treatment, of course, is one of the most effective measures to prevent opioid overdose, provide drug dependence treatment in prisons, and of course, the treatment of opioid overdose with naloxone. But also we expanded on new areas. So for example, naloxone has been traditionally used by medical staff to treat opioid overdose, and the new approach described in these guidelines was to distribute naloxone also to first responders, such as police and firemen, and to people dependent on opioids, their peer and then family members. These are all people who are likely to be present when an overdose occurs and can act quickly if appropriately trained. And of course, we are basing ourselves on the guidelines produced by WHO, and both these documents were taken over by the standards that I was mentioning to you, but these are the original document on which our work was based. We had also very strong mandate from our member states that asked where the member states decided to promote the inclusion of prevention and treatment of drug overdoses in national policies and system of treatment in the outcome document of the 2016 United Nations General Assembly Special Session of the World Drug Problem. So we had really strong agreement from our member states, all of them, to work on this. And in that context, we launched the SOS initiative in March 2017, and we had some really, really nice targets. We wanted that 90% of the relevant target groups would have received training in overdose risk and emergency management, so 90% trained. And of these trained, we wanted that 90% would have been given a supply of emergency naloxone. And then that of those trained, 90% and given a supply, 90% would be carrying the naloxone on them or have it close to hand to be able to use it in case of need. So 90-90-90. And this is what we implemented in Kyrgyzstan, Kazakhstan, Tajikistan, and Ukraine. And this is the kind of process that we followed. It was a bit long, and you might look at here. The assessment and preparatory phase went from May-December 2016 to June 2019. It took a lot of time to prepare the protocols, to agree with the national government. But once we were ready, the implementation phase went like this. It was a matter of 6 months, and we managed to reach all of these people likely to witness an overdose and collect the data and do a very good study. And here you have some pictures from the various phases, and with some ideas about the evaluation. What I would like to highlight is that we have published all of the evaluation study and protocols. Sorry, we have the protocols available, but we have not published them. But here in the summary report, you will find a very, very good summary of the methodologies that we use, not only to implement, but also to study and to arrive at the evaluation. And also we had a lot of national adaptation, and the colleagues that have been implementing SOS are going on with this work. So before the SOS, for example, in Kyrgyzstan, the colleagues were remembering that many ampoules of naloxone would be lost because they would get broken. So with our implementation partner, the Harm Reduction Network frontline staff, they thought about and successfully manufactured the take-home naloxone kits using really, really cheap and convenient cable ducts that would allow us to have safe boxes with sliding top covers to carry the naloxone safely and not getting it lost. And also in Kyrgyzstan, we saw plastic containers manufactured by people who use drugs by themselves for themselves, including the following items that were in line with the WHO standards, with the UNODC standards, and of course with our study. We did save lives. So what you don't see in this in this slide, oh no, it is this. Our project sample was 14,000 more or plus people. This means that we trained. Actually, we trained a bit more, like 16,000 people, and we provided 14,000 people with training and the ampoules. And we studied a sample from this cohort, and the study did suggest that 90% of these people had been carrying the naloxone around, like we were striving to achieve. And this and they used it correctly. So, for example, SOS implementation, and this is our estimate, may have resulted in naloxone administration by as many as 4,388 individuals and an estimated almost 400 lives saved. I would have been happy with one, but it's important that, of course, we can demonstrate really strong effectiveness. And I think that this is a case in which we have demonstrated the feasibility of using naloxone in this context with people likely to witness an overdose or take home naloxone, as it is sometimes called, not only in high-income countries, we had solid evidence from that already, but also in low and middle-income countries. And we showed how using take-home naloxone is effective in saving lives while not increasing drug use. I invite you all to consult the result, and here I would like to show you there. You don't only see some colleagues that have been involved in SOS, but together with WHO, we also created a film about life, which I would like to show to you precisely to commemorate International Overdose Awareness Day. And hopefully this will work. Let me try.
This is a film about life, about hope, of actions that make a difference. And it's about our future. It's also a story about people who help change lives, people who help save lives. And it's also about remembering, not forgetting. Remember the 500,000 mothers, fathers, sons and daughters who lose their lives to drug use every year.
It's not something that Jonathan did or didn't do. He was the son that any mother would have wanted her son to grow up to be. Unfortunately, we still don't know what makes someone vulnerable to develop addiction. He deserved to live a life like any of us. He would have been the kind of person that you would have interacted with in your daily basis and would not have thought twice that he had a problem, that he had this terrible, terrible disease. That's why his death was such a shock for our community, because he was a good person. He deserves a legacy, and I will make sure that he has that.
Each year, at least 115,000 people die from an opioid overdose. But we have the chance to reduce that figure. We have the chance to make a difference. And effective solutions already exist, most of which operate at the community level.
It doesn't just change an individual when you treat somebody with drug use. It changes a family, it changes a community. And you have a team of outreach workers who go out to the community and identify these persons who have the need for methadone maintenance therapy, psychosocial support, and other interventions as per the assessment of their needs. Psychosocial intervention is quite a wide range, ranging from psychological services, social skills improvement, family integration, people who come when they are unkempt, they are dirty, they are homeless, they are malnourished, they come back and they restore their human dignity. It gives you job satisfaction because you go to work and you know you're going to change somebody's life.
This success story in Kenya is one of many community-based programs that is a cost-effective and high-impact solution. But there are many more successful initiatives happening all over the world.
Люди, когда приходят к нам, они привыкли к тому, что им никто не хочет помочь. И когда они видят принятие, поддержку и конкретную помощь здесь и сейчас, это очень подбадривает. Мы обучаем людей о том, что такое передозировка, то есть рассказываем, какие они бывают, какие симптомы и как можно помочь человеку, если вы увидели передозировку, если стали свидетелем передозировки.
Тоже рассказываю про Naloxone, чтобы он был в доступе, как им пользоваться и чтобы избежать смертельных передозировок.
Наркозависимые люди, когда чувствуют принятие и поддержку, они готовы меняться сами и отдавать обществу тоже только хорошее.
People are helping people. Never has collaboration been more important. Ideas that have been approved at the highest level are working at local levels.
The SOS project, Stop Overdose Safely, is a really wonderful project. Within the project, we provided services to more than 5,000 people. We provided them with kits with Naloxone and with unique training. We trained 5 master trainers and 54 national trainers who provided training to people who live with people who are under utmost risk of suffering from overdose. Without the support from WHO and UNODC, this project would be impossible.
Right now, we have an opportunity to realize that we can scale up overdose prevention activities. Today we can act to make a difference. Today we can help to break the stigma. Today we can stop thousands of unnecessary deaths. Drug dependence is not a choice. It never has been. It's a complex mental health condition and not a self-acquired bad habit. It can be prevented and properly addressed to improve life and well-being of people. It should be an integral part of primary health care and universal health coverage. Today, we invest. Tomorrow, we move forward.
Thank you.
Thank you, Maria Augusta. Also, thank you to Giovanna, who sent this very nice message to all of us. There we are. It's almost 2 hours, much more than we expected, than we planned at the beginning. And I'm glad that we had such nice and good presentations from all of them, of you who did it. I'm glad that we had kind of 40 people and more coming from, as I said, different corners of our region and outside of the region. And I think it was, at least I think it was useful. There is one sentence which actually came to my mind just now at the beginning. It's something which Felipe said in his presentation, that in 1990, when some of these things started, there was so many misunderstandings between different partners, and we are all in the same business. We are all doing our small piece of bigger attempt to help people fighting with the problem they have. And I think it's very good, as Liz just said, to have so many allies together. And I hope that this will be replicated in our region, where we normally have good understanding of each other, but not always such good working together on this. As Nebojša said in the beginning, that we already scheduled the meeting for 10th of September in Belgrade, where the Office for Combating Drugs in Serbia will gather all the institutions that should be involved in the process of trying to make wider distribution of naloxone working. There will be people from the Ministry of Health and Police, from Institute of Public Health, for the Health Fund, from the key hospital, which is dealing with all the accidents, and a couple of us from civil society. And I'm quite sure that we'll get a step forward, as I said in the beginning, but I'm sure we will do something. Thank you all. As I mentioned in one of the last chats, if somebody wants to have a quick recording, I will later, when we finish later in the evening, I will have the link from Zoom directly if you want. But then otherwise, I can give you. Then you just drop me a message on my email address, and I will send this quick link to you already this evening. Just a small private thing. It's I'm expecting my daughter to give birth, so I might be late a little. Okay, thank you all. Have a nice afternoon and evening, and I hope to see you soon on a similar event as soon as possible. Thank you. Bye.
Thank you, everybody.
Thank you very much.
Thank you.
Thank you so much. Bye.
Bye.
Thank you. Thank you. Bye, guys. Bye, Milutin. Thank you for the invitation.
Bye. Thank you.
Thanks a lot. Thank you very much. Bye. Bye.
Thank you. It was very nice. Very good.